Welcome back to Decode Healthcare with Harshal. Now, if you're a focused learner, you'll remember that in part 2 of this explainer series, we completely decoded the accessory sinuses. Well, today we're following the airway and moving further down the throat. We're going to completely decode the larynx section of your CPT codebook. We are talking specifically about codes 31300 through 31599. Honestly, if you want to conquer respiratory coding, you absolutely have to master this section.
Here is our roadmap for today. We've got anatomy of the voice box, excision and laryngectomy codes, emergency endotracheal intubation, the strict difference between direct and indirect endoscopy, and finally, repairing the larynx. Let's just jump right in. Starting with Section 1, the anatomy of the voice box. Okay, let's dive into this, because before we can accurately code any surgical procedure, we literally have to know exactly where we are operating. Take a look right below the oral cavity, just past the epiglottis. Right there, you'll see the larynx. It sits right at the top of the neck, basically acting as the gateway down into the trachea, which is your windpipe. Now, understanding this strategic position is absolutely key, because any procedure happening here is dealing directly with the intersection of how a patient breathes and how they speak. To put it in plain, simple English, your larynx is your voice box. It has two main, highly critical jobs. First, it holds your vocal cords, which vibrate to create sound so we can actually speak. Second, and arguably most importantly from a survival standpoint, it acts as a protective shield. When you swallow, parts of the larynx, like the epiglottis, close off the windpipe. This ensures that food and liquid go down your esophagus to your stomach and not into your lungs. Moving on to Section 2, excision and laryngectomy codes. Now that we're clear on what the larynx does, let's look at surgical removals. In your CPT book, the excision codes run from 31300 down to 31420, and notice the sheer scale of the procedures covered here. On the lighter end, you have code 31300, which is a laryngotomy, where the surgeon makes an incision just to remove a localized tumor. But as you move down the list, you hit codes like 31370 for a partial removal, or code 31360, which represents the surgical removal of the entire voice box. I really want to emphasize the clinical reality behind code 31360, the total laryngectomy. This is not a minor biopsy. This is the surgical removal of the entire voice box, usually to fight an aggressive cancer. When a patient undergoes a total laryngectomy, their anatomy is permanently altered. Their windpipe is disconnected from their mouth and nose, and it's surgically attached to a stoma, a literal hole in their neck so they can breathe. They permanently lose their natural vocal cords. Keeping this drastic physical change in mind really helps you, as a coder, understand the gravity of what code 31360 represents. All right, Section 3, emergency endotracheal intubation. Let's transition over to the introduction section of the CPT manual for the larynx. There is a massive, highly utilized code sitting right here that every medical coder needs to know inside and out. And that code is 31500. You're going to see this code constantly in emergency departments and critical care settings. It is a literal life-saving procedure. Code 31500 is for emergency endotracheal intubation. Picture this. A doctor uses a specialized tool called a laryngoscope blade to gently lift the tongue and epiglottis out of the way. Then, they carefully slide a flexible plastic tube through the mouth, straight past those vocal cords we just talked about, and down into the windpipe. This physically connects an unconscious or struggling patient to a mechanical ventilator so a machine can breathe for them. It's urgent, it's mechanical, and it is neatly captured by code 31500. Okay, Section 4, direct versus indirect endoscopy. Pay really close attention here, because this is absolutely the most critical coding lesson of today's explainer. You have to know the CPT guidelines separating these two methods. I like to call this the mirror versus tube analogy, and indirect laryngoscopy, like code 31505, is exactly what it sounds like. The doctor places a tiny, angled dental mirror at the back of the patient's throat and shines a light on it to reflect the image of the vocal cords up to their eyes. Crucially, no scope goes down the throat. On the flip side, a direct laryngoscopy, starting with code 31515, involves physically inserting a rigid hollow metal tube or a flexible fiber optic camera directly down the patient's throat. They're looking directly at the anatomy, not a reflection. So, rule of thumb, if a physical tube or camera goes down the airway, it's direct. If it's just a mirror at the back of the throat, it's indirect. Now, what's really interesting about this rule set in the CPT book is how the AMA draws a hard line between midline structures and paired structures. Midline structures, like the epiglottis, are single anatomical sites, but paired structures, like your true vocal cords, are considered unilateral for coding purposes. The rule explicitly states that if you use an operating microscope or telescope on a paired structure, you use the applicable code only once per operative session. You do not bill it twice just because there are two vocal cords. Make sense?
So, what should you take away from all this? When you're staring at a dense operative report, you need an actionable checklist. Here is exactly what you need to isolate to find the right endoscopy code. Step 1. Ask yourself, was it an indirect mirror or a direct inserted scope? Step 2. If it was direct, you must scan the report to see if the surgeon used a rigid tube or a flexible fiber optic one. And finally, Step 3. Was the procedure purely diagnostic, meaning they just looked around, or was it surgical, where they actually removed a vocal cord polyp, injected something, or cleared out a foreign body? Answer those 3 questions, and the codebook practically hands you the correct code.
Finally, Section 5, Repairing the Larynx. Let's end our journey down the throat on a positive, restorative note.
The repair codes, which run from 311580 to 3159, are all about fixing damaged anatomy. We aren't removing tumors or just looking around anymore. Procedures like a laryngostoplasty focus on physically rebuilding a crushed, damaged, or abnormally narrow voice box. Surgeons might use small pieces of cartilage grafts, harvested from elsewhere, to reconstruct and widen a narrowed airway so the patient can actually breathe normally again. They might also use indwelling stents to hold that airway open while it heals. It's truly fascinating stuff.
So the crucial point today is that understanding the physical function of the larynx and distinguishing between a mirror and a physical scope is your key to conquering these codes. But consider this. Every time you code 31500 or 31360, you aren't just filing paperwork. You are documenting the exact moment a patient's ability to speak or breathe was fundamentally altered or completely saved. Once we pass those vocal cords, where does the airway go next? Well, be sure to subscribe and join me for Part 4 of Decoding Healthcare with Harshal, where we follow the airway deeper into the chest to decode the trachea and bronchi. Until then, keep learning.